Advanced manual therapy techniques for the pelvis and sacroiliac joint. Modified patient positioning, street leg cases, particularly those involving degenerative changes, joint replacements, or structural limitations in the lower extremity. Traditional flex leg positioning may be inappropriate or intolerable for the patient. Simple yet effective modification involves placing straight out in front of them, as opposed to the typical 90-degree flexed hip and knee position. This positioning significantly increases the leverage available to the practitioner, creating a longer lever arm during manipulation. While this can be advantageous, it also necessitates increased attentiveness when feeling for end-range tension and joint barriers, as excessive force may compromise patient comfort or safety. Manual therapy of the pelvis and SI joint. Foundational concepts. Since the late 19th century, manipulation of the pelvic complex, including the ilium, sacrum, and associated soft tissues, has evolved from an emerging technique into a foundational component of contemporary manual therapy. This growth has been driven by consistent clinical reports of immediate symptom relief following targeted manipulations of the pelvic floor. Notably, functions such as anterior or posterior innominate rotations, sacral torsions, and ligamentous strain-related nerve entrapments are frequently identified as primary contributors to lower back, hip, and buttock pain radiating into the lower extremities. Manual therapy aims not only to restore proper joint alignment and biomechanical function, but also to relieve neural irritation, enhance muscular balance, and improve proprioceptive input in the region. Two major manipulative categories are commonly utilized: high-velocity, low-amplitude thrust, HVLA, low-velocity, low-amplitude mobilizations. Both techniques are chosen based on patient presentation, pathology, and practitioner preference, provided contraindications are ruled out. Contraindications and clinical safety. Before initiating any manipulative procedure in the pelvic or SI region, the practitioner must thoroughly screen for contraindications. Absolute contraindications include, but are not limited to, severe osteoporosis, metastatic bone disease, cauda equina syndrome, recent fractures, or infections such as osteomyelitis. Relative contraindications, such as recent surgery, joint replacements, or anticoagulant therapy, necessitate modified approaches or alternative techniques. Clinical reasoning, combined with anatomical knowledge and diagnostic sensitivity, is critical to ensure manipulation is both safe and effective. Practitioners should only employ these techniques following formal education, hands-on training, and supervised clinical experience. According to both the World Health Organization and peer-reviewed literature, inadequate training is strongly correlated with adverse outcomes. Pelvic and SI joint anatomy in context. The pelvis acts as a mechanical and functional bridge between the spine and the lower limbs. It comprises the sacrum, coccyx, and a pair of fused coxal bones, each formed from the ilium, ischium, and pubis. These components articulate at several key joints: sacroiliac joints, right and left, pubic symphysis, lumbosacral junction, hip joints, femoropelvic articulation. Each joint plays a role in weight transmission, shock absorption, and load transfer during gait and other functional activities. While the hip joint allows movement across three planes: flexion extension, abduction adduction, and medial lateral rotation, the sacroiliac joint is a much more stable structure. Once considered immobile outside of pregnancy or pathology, it is now recognized to allow subtle but important screw-like motion, especially during functional tasks such as walking or squatting. Common injuries and red flags. Pelvic injuries frequently result from high-energy trauma, motor vehicle accidents, sports injuries, or falls, but can also arise from repetitive strain or chronic postural adaptations. Pain syndromes involving the sacroiliac joint are especially common in athletes, pregnant individuals, and sedentary populations. Key red flag indicators to watch for include progressive neurological deficits, bowel or bladder dysfunction, unexplained weight loss, fever and systemic signs of infection, history of malignancy, severe, unrelenting nighttime pain. Any of these signs should prompt urgent referral and diagnostic imaging, and manipulation should be deferred until serious pathology is excluded. Technique 1. Anterior ilium correction. Prone HVLAT. This technique is particularly
Bene,
effective
lascia
for
capire
addressing a
tutto,
perceived
manata.
anterior innominate dysfunction. Steps. 1. Position the patient prone with a small pillow under the abdomen to reduce lumbar lordosis. 2. Stand on the involved side. 3. Place one forearm along the PSIS and iliac crest. The other hand reaches under the patient's thigh on the same side. 4. Interlock your hands, lifting the thigh into mild extension and adduction until a firm barrier is felt. 5. Maintain the tension and apply a controlled HVLA thrust through the PSIS using your forearm. Key considerations. Avoid this technique if the patient has significant lumbar pathology or prosthetic knee. Do not overextend or hyperadduct the leg. Minimal motion is often sufficient. Audible cavitation may not occur. Rely on clinical reassessment for efficacy. Technique 2. Supine SI joint manipulation, Chicago style. This technique targets the SI joint using a classic supine setup with rotational emphasis.